us or not, but let's to respect those who have been on time, I would suggest we started. So today we are going to have two more lectures. The first one of them would be assessment of renal function, and you would ask yourself, hey, uh, we have been talking about this kidney disease for a week and a half, and now you're coming and telling us how to assess the renal function. Yes, in a way, probably this should be one of the very first lectures you have at the beginning, but I'm going to include some of the things that not only you have already learned last week, but we are going to use it for the rest of our week this week. Let's start with a case. So we have Mr. Paul Turner, 65-year-old gentleman who is coming to our nephrology clinic for evaluation of renal function. Okay. So word of wisdom. If we want to know how to assess an organ's performance, first need to know what is its function, right? To assess the function. So what is the function of the kidney? The function of the kidney is filtration and elimination. Number one. Let me, before I go there, let me tell you something. Kidneys do a lot of stuff actually. Some of the things you might not even know about them, and we are not going to talk about it. We pick a few of them that we want to discuss. Otherwise, if you go to these books, whatever you are getting ready for the USMLE, you will see it can be a long list of things that kidney do. But we pick the ones that are more important for this lecture. Filtration and elimination is probably the most important function of the kidney. Homeostatic regulation, water and acid base. Acid base, I think you learned about it last week. Water balance, we are going to talk about it today, second session. Endocrine function in the hormones, we talked about the renin, right? Where is renin secreted from? That was angiotensinogen, the liver. Where is the? I know it's the kidney. Where in the kidney? Yes, JGA. Yes, juxtaglomerular apparatus, which includes macula densa. Perfect. Excellent. Okay. So going back to filtration and elimination, let's see what it says. It says removal of organic waste products. As we are alive, we are metabolizing things. As we metabolize things, there will be some waste products. That's the bottom line. If you are alive, you will have waste products. That's number one thing. Okay. So, but the trick is what we call them uremic toxins. If you ask me what are uremic toxins, I tell you they're long list. Some people say 60, some people say more than that. Uremic. Basically, it's a collection of things that are bad for us. Two of them you are very familiar with: urea, creatinine. But there are lots of other waste products that we don't talk about it. You will be surprised to know that vitamin C, ascorbic acid, is a waste product. There are lots of things that you would be surprised to know that these are waste products. But we pick two of them that we'll discuss. Okay? So uremic toxins, we want to get rid of the uremic toxins without losing blood, protein, or cells. So remember, there's a catch about it. We are removing the waste products without those two. And you will see how important it is in assessment of renal function. Basically, look at me as somebody who's driving this truck. My job as a nephrologist is to get rid of the waste products in a nice way. Do I look like somebody who drives this? Probably. Okay. How can we evaluate renal function? Rule number one: all kidney functions parallel the filtration. What am I saying here? I say, hey, these are all the list of the functions that a kidney has. Pick the filtration part. All others parallel with this. If it is great, these are great. If this is going down, the other ones are going down. You heard about it yesterday. When I was talking about potassium, I told you, okay, the job of the kidney is potassium absorption, secretion, and all those. Then I was telling you, somebody who has chronic kidney disease will have a low ability to get rid of potassium. Do you remember that? That lady who had gotten tomato juice and all those hyperkalemia. Do you remember that case? Basically, at that time, I told you filtration is coming down. kidney disease, chronic kidney disease has, the elimination part of potassium is down. The elimination part of acids is down. Magnesium is down. Everything that the kidney was doing parallels this big thing of filtration. Does that make sense? So that's why you and I, we take filtration as the big marker of kidney function, and then we adjust everything else based on this filtration. Does that make sense? Does it? Perfect. I move so much sometimes I forget my. Okay, so number one, all kidney functions parallel filtration. The second one, you know it already. Filtration happens in the glomerulus, right? That's where the blood comes. That's the big glomerulus. Then the tubules start and it is filtered in, right? Okay. These two, when you know, then you have GFR, glomerular filtration rate, will become the standard assessment of renal function. Does it make sense now? You take the glomerular filtration rate and you adjust everything based on this. If my GFR is down, my ability to get rid of potassium will be down. My ability to do homeostasis for acid base is down. Everything will be parallel to this. Does that make sense? Perfect. Okay. If you think about it, kidney is a big filter. The reality is, kidney is this, a sophisticated this. We start with the blood coming to the glomerulus is the filtration comes here. You know about the filtration barrier. There are three layers. The blood here is pushed. There is a lot of forces. It's pushed into this. The primitive urine goes to the other side, which is the tubules. You see it over there. Then in the tubules, it start to move. All the changes happen after the filtration. Potassium is reabsorbed, amino acid is reabsorbed, glucose is reabsorbed, creatinine is secreted. Everything is happening along these tubules until you and I we have access to this. So basically, we go from the blood to the urine. That's the function of the kidney. Does that make sense? Does it? Very good. So if you say the product of the kidney is urine, you are going to make me very mad. The job of me is just to take care of something that makes urine? No, it's a byproduct. It's like saying that the factory's product is pollution. No, I want to have homeostasis, and you are getting a lot of potassium. I get rid of potassium. My job is to keep your blood volume to a certain extent, and you are not drinking enough. My job is to absorb water. So the urine is the byproduct after I have made some changes to keep you within the normal range. Does that make sense? That's why it's a byproduct. And that's why the urine should have the main capacity to change a lot so the serum will stay as stable as it can be. Does that make sense or is becoming philosophical? You're going to through this and you're going to understand it. Just give yourself time. Remember what I told you. Planned repetition. You are going to hear from me several times these concepts. The product is homeostasis. It's not the urine. My product, the product of my organ is that to keep you within normal range. For that, the urine will be generated. Okay. Starting with the sophisticated filter that I told you. I told you the reality is kidney is a sophisticated filter. It has three components that we need to memorize. Super important for the board and for clinical practice. Number one, fenestrated endothelium. It's an endothelium, but it is very different from the usual endothelium that you have elsewhere because it is fenestrated. Does anybody know Spanish here? You don't know? Not even so. What is fenestrated? Fenest. Does anybody know French? Window. God bless your heart. Yeah. Fenestrated endothelium. Fenêtre in French means window, basically. Fenêtre, I think it's in Spanish is the same. It means you that you have the epithelial cells, but they are a little bit separate from each other. They allow things to pass between them, right? Fenestrated, a special form of endothelium. The neck, this is the fenestra, the gap. The next one would be the basement membrane, a major matrix. The third one is a special form of epithelium that we call podocytes. And you have heard about it quite a bit because you will have glomerulonephritis that is just dealing with this. So blood on this side, pushed from here, what you will hear, whatever is moving here, here you will have the urine. Okay. If you look at it, the three-dimensional, and please note that the colors do not match. This is from a different reference. So the colors, don't go for the colors. So the blood is going inside. First layer around this is the fenestrated endothelium, then is the basement membrane, and then it is the food processes of the epithelium. The three of them are around each other, right? So basically, the blood goes in and the urine comes out. Are we good? Perfect. This is the filtration. So if I ask you, there is a medical student who is doing a research project on filtration, which of the following would not apply to his research project? I put these three. The fourth one I put, let's say, proximal tubule. What would the answer? Proximal tubule. These three, right? Silly question, just to give you an idea that how the questions will be made. These three are part of our filtration. Okay, so now GFR, I told you the standard of assessment of kidney function. Then you are going to ask me, so Amir, tell us how GFR is going to be measured. Sure enough, very valid question. We should find some kind of a component. Let's call it X. This X, what should it have to be good? Number one is that it should always be in the blood. It can't be sometimes that sometimes some people have it in the blood, some people don't have it, some people have it at different. It should always be in the blood, right? If we are wanting to somebody that is a standard for assessment of renal function, we are looking at this compound. Second is that that X should be freely filtered in the kidney, meaning that it is moving in the circulation in the blood. When it comes to the kidney, goes to the glomerulus, it should be freely filtered. Nothing should hold it back, right? Because we are going to count on this as the measure of filtration. We want it to be as smooth as possible because we want to basically see what is in the blood, what is in the urine. The difference would be the filtration, right? So we want it to be filtered very easily. What is the third aspect of it? It should not be transported. So after it is filtered, when it comes to the tubules, it should not change much because we don't have access to what is in the tubule. We have access just to urine, which is at the end. All the changes have happened in the proximal tubule, distal tubule, loop of Henle. So the less the change, the better would be the measurement. Does that make sense? So we want basically something that is constant in the blood, comes to the kidney, filters easily, and then in the tubules is not moving much, does not get absorbed much, does not get secreted much, stays pretty much the same until we get it in the urine so we can measure it. Does that make sense? Okay. Creatinine would be a good option, in my opinion. Why? Number one, it is produced by our muscles. So it is constant in the blood. You can't say, oh, I don't have creatinine in my body. There is no way. If you're alive, if you have muscles, you have creatinine, and it is stable. It's not that at 6 p.m. you have something, at 6 a.m. you have something else. Constant in the body. Second, it's not reabsorbed. When it is filtered, first of all, it is freely filtered. It comes, whatever creatinine comes to the glomerulus will be all filtered freely, no problem. Nothing holds it back. Then when it comes to the tubules, it goes through minimal change. Realize I didn't say no change. I said minimal change. And I will tell you in a second why. It is not, I say here, it's not reabsorbed in the tubules. So whatever you have here has come from the filtration, has not gone through a lot of changes. And last thing is that it is inexpensive. What are the problems with creatinine? The problems are it has a little bit of secretion here. That's the problem. Meaning that, so if it is a little bit of secretion at the level of proximal tubule, I have a question for you. Think about it before saying yes or no. The urine that I have here, if I check the amount of creatinine that is inside this urine here, will be more than the filtration, what was filtered, or less than what was filtered. If we have some secretion. What are your thoughts? You can say something. You don't have to be right. That's why you are here. More, yeah, absolutely. Listen, you have had some filtration here, then it was secreted into. There was some creatinine that went inside it. Then you get all the creatinine here. So the creatinine that you get here is not only what was filtered, but a little bit of what was added to it, secreted into the tubules. So it overestimates your filtration. Would you agree with me? The urine creatinine would overestimate my filtration by 10 to 20%. Then tubular secretion increases in some situations and then may account for as much as 50% in some issues. So clearance of creatinine rate can exceed actual GFR by 50%, overestimates. Nothing is perfect. So far we know that creatinine is a good measure, but we know about its limitation. Its main limitation is that 10 to 20% of it is secreted into the tubule, so it overestimates the filtration. What we get here is a little bit more than what was really filtered. Okay, so clearance of creatinine equals GFR. We can use it knowing that limitation, okay? So the normal is 100. If you want to remember it, clearance of creatinine is like IQ. It's around 100 is good. The more, the better, right? Okay. So how do we measure clearance of creatinine? The clearance of creatinine will be our GFR. And remember, we said GFR would be our standard assessment of the kidney. Clearance of creatinine, this is something you and I, we need to memorize. Urine creatinine times urine volume divided by serum or plasma creatinine. And again and again and again, remember the units. These two should be milligram per deciliter or whatever that is close to each other that they can cancel. So the main unit of the clearance of creatinine would be milliliter per minute. Basically, it's the amount of blood that is cleared out of creatinine. This is the definition of clearance of creatinine. The volume or amount of blood that is cleared from creatinine in 1 minute in a unit of time. Right? Because these two will cancel. Okay? And if you want to remember it fast, that's how I remembered it. UV over P, UV over P, UV over P. You just make it right, rhythmic to you, so you will remember it. U is urine creatinine, V is volume of the urine, P is plasma creatinine. UV over P, UV over P, or whatever you like to learn it. So this is the clearance of creatinine. And think about it. Any clearance can be UV over P. If for creatinine it is, you put urine creatinine, urine volume, plasma creatinine. If I tell you, tell me about the clearance of phosphorus, you see urine phosphorus times urine volume divided by serum phosphorus. Everything, right? We said creatinine is a good measure, but we didn't say that others cannot be used. Okay, our Mr. Turner has an assessment of the kidney function, came to us. Let's check his clearance of creatinine. He came to us to tell him about his kidney function. What labs do you think we need for to assess his kidney function? You have the labs that you need, the three of them here. You check his urine creatinine. You ask him to keep his urine for 24 hours, urine volume, and then you check serum creatinine, right? Three things that you need. So what labs do we need? Remember, it is a timed thing because it is the urine volume per 24 hours. Just make sure you don't say, oh, his urine volume is 1200. 1200 in what unit? In half a day, in 5 days, in a week, in 3 days. Does that make sense? It's a timed volume. Keep that in mind. I put it in. Okay. Here are his results. His plasma creatinine is 0.9 milligrams per deciliter. He had 2.8 liters of urine in 24 hours, which is good. And then urine creatinine is 50 milligrams per deciliter. Should we put it in the equation here? Let's do it. 50 times 2. Why did I put 2? Because I said it is 2880 milliliter in 24 hours, and every 24 hours has how many minutes? 1440. Very, very, very good. 24 times 60, right? So milliliter per minute. So 2880 divided by 24 hours makes it 2 milliliters per minute. You can practice it in your mind. 1440 is something that the nephrologists know, but you probably don't want to memorize it. So his clearance of creatinine is 111 milliliter per minute, which is perfect. Excellent news for Mr. Turner. Are we good? For this, I needed to keep 24 hours. Is it easy to keep 24-hour urine? Easier said than done. Think about it. When I ask my patient, hey, you need to keep your urine for 24 hours, it means that he cannot go far from that bathroom. He needs to keep that jar in that bathroom. He cannot go out. He cannot do anything because if he goes out and he needs to pee, messed up. You need to restart, right? And then you have a jar over there. Everybody that goes to the bathroom is looking at your urine, right? Not fun. Then you forget because we tell them when you wake up in the morning, you throw away your first urine of the night or from the day, and then you keep your urine. And the next morning, when you wake up, the first urine of the day goes in that jar, the 24-hour. Kind of complicated. You say this to a 72-year-old woman before she leaves your office, she has forgotten what you told her. So 24-hour urine is cumbersome. It's doable, it is done, but it is cumbersome. We should accept that. For routine practice for everyone, it's impractical, I would say. Okay, fact number one, 24-hour urine is difficult and impractical. Perfect. Second, we know that for compound X, more filtration means less in the blood, right? It's not rocket science. Less filtration, higher level in the blood because it's not filtered, right? It's really not rocket science. It's just common sense, right? So if you put both of these together, I would say, why don't I use just serum creatinine? Just use serum creatinine. It has come from his muscle. If it goes up, I say less filtration. If it is low, I say good filtration. At first, it sounds not a bad idea, and it is not really a bad idea, but it has some caveats that you and I we should know. What are the caveats? Number one, serum creatinine level is not perfect because its relationship with GFR is not linear. What it means is that you see here, it is serum creatinine going up, and this is my GFR. Okay, think about it. GFR is super high when my serum creatinine is less than 1. Look, perfect kidneys. Okay, my serum creatinine goes up, says that the GFR is coming down. But think about it this way. I am in the clinic. I saw a patient. His serum creatinine was zero 0.8 3 months ago. Comes to see me today. His creatinine is 1.2. Zero 0.4 has gone up from zero 0.8 to 1.2. So his creatinine was around here, 100 of GFR, 1.3 here. All of a sudden, less than 10, less than 50 is the GFR, less than 45 actually. It's around here. Just by zero 0.4 increase in serum creatinine, major drop in my GFR, right? But look at the other patient that I have. His creatinine is 3.8 3 months ago. Now has come, the creatinine is 6. The GFR is pretty much the same, actually. That's the GFR. The point is, in lower levels of serum creatinine, a small change delineates a major change in GFR. But in higher levels of creatinine, a major change does not mean a lot of change in the GFR. Does that make sense? That's why some people think nephrologists are crazy. We probably are, but not because of this. They see that in the hospital, they consult me for a GFR of 1.2 that was 1.8. I'm jumping up and down, asking for labs, doing things. But for the other patient, I'm so cool about it. Creatine was 4, now it is 6. They don't understand the reasoning. The reasoning is this diagram. So basically, that's what it says here. An equal change in serum creatinine does not equal and change, does not mean and equal change in GFR. Does that make sense to you guys? Does it? That's why serum creatinine is good, but it is not perfect. That was caveat number one. There is another caveat about serum creatinine, and it is this. Remember, creatinine is coming from creatine, which is in the muscle. Those guys who go for bodybuilding, those ones to have six packs and all those, they get creatine. Did you know that? They don't tell you, but they take it. They say no, 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 but they take it. That's for the muscle. Okay. So what happens is that what if I don't have a lot of muscle? If my serum creatinine is one, and the guy who is a major bodybuilder, the serum creatinine is one, our kidneys should not be the same. Does that make sense? Yeah. Here I have shown this. This lady, she doesn't have any muscle. That's why probably she's grumpy. She doesn't have any muscle. If her serum creatinine is 1.5, this guy or this guy, the creatinine is 1.5, there's a difference between their kidney function. Would you agree with me? Okay. Less muscle mass in women, older age, and I just put a line on white race. I kept it because up until 3 years ago, I was teaching and say there are three things that just affect the kidney, the muscle mass. One is the gender, women, one is the age, and one is the race. Now we realize that race should not have been here. So I put it here to remind myself, to remind you, do not keep in mind the race. And tomorrow I will tell you why. For now, you and I, we know that less muscle mass will have in women and older age. So if this guy's creatinine is 2.5, probably a little bit of kidney dysfunction. 2.5 is too much. Normal should be around 1. 2.5 for this lady, close to dialysis. You see the difference? So serum creatinine alone is not a perfect measure. We need to make it better. Okay. So how should we make it better? Let's take into account those two caveats that I told you. Relationship with GFR is not linear, and there are other things that change the muscle mass. Okay? How do we take them into account? We come up with some equations, with some formulae to more precisely estimate GFR. Basically, I put serum creatinine, I add it into some other stuff and come up with a number to make serum creatinine a better marker. What is one of them is called MDRD equation, MDRD. And if you wonder what MDRD stands for, I wrote it here for you. That's the name of the study that was done. MDRD came out of it. So what does it include? I put it in red because you and I, we should memorize it. It includes age, we said older age. Gender makes sense. I put that old lady over there so you remember everything about that. A gender, race, and serum creatinine. Race, you will see that we are going to remove it. Okay, so serum creatinine should be there to begin with. We use serum creatinine to come up with this. Age and gender are there. So this is the formula. I know this formula, right? No, I have never learned it. Nobody has asked me to learn it. I put it there for you just to know. You don't learn this. That's why you have Google. That's why you have the laptops. MDRD GFR was the most commonly used method for evaluation of renal function until recently. And now it's changed. You will see how. Another one is called CKD EPI. CKD is chronic kidney disease. EPI is epidemiology. Okay. This is another one. This one has age, gender, serum creatinine, can have race or not. Just is practically it is like MDRD. Age, gender, race, yes or no, serum creatinine, right? These two are close to each other, but obviously the formulae are very different. So it gives us an eGFR, estimated GFR, right? Which is different. Okay. eGFR without race, and it is important, without race was recommended in 2021 what National Kidney Foundation, American Society of Nephrology, as a preferred method for evaluation of renal function. If in a question somebody asks you what is the standard measurement for eGFR today, 2025, March, CKD, epi without race. Tattoo it in your brain. Okay, you can go to Google, just Google it, CKD epi, GFR. 200 calculators come. This is one of them. I use it because it has National Kidney Foundation, but all of them are pretty much the same. Do you want to give it a try and put these numbers for Mr. Turner and see what it can become up with? Let's calculate his estimated GFR. Okay. So you see serum creatinine, age, gender. This is all you need. 0.9 is serum creatinine. His age, we said it is 65. Then gender, we said male versus female. The rest is nonsense. Standardized and all those, you don't have to worry about it. And we push the calculate. Here we are. His estimated GFR comes out at 95. And if you want to Google it, come up with another calculator, you will see it's the same. Okay, so we estimated. In the first place, we did 24-hour urine. We checked his clearance of creatinine to see what the GFR is. Now we just did serum creatinine. We estimated his GFR. It is kind of close. It's not perfect. It's not 111, but it is not 25, right? Okay. If you think about it, today you learn something about yourself. Each one of you has a GFR. You know about the color of your hair, color of your eye, your height, your weight. But you didn't know that you have a GFR. Every single one of you has a GFR. Just to give it a fun try. This is, let's put classic. You guys that have around zero point 0.7 would be your serum creatinine if you don't have kidney disease. I put the age at 25. I put a female because many people are female in this classroom. Think about it. What did it come out? CKD epi of 123. You see? You learn something about yourself. You can use it if you have had labs recently. You can go put your GFR. Sometimes you can use it in social things. Somebody asks you out. You tell them, you know what? I would have loved to go out with you. But in our family, we don't go out with a GFR of less than 100. I'm sorry. Right? You can use it in different situations if you think about it. So you learn something about yourself. One thing that is important to remember is that GFR is like every other thing, like every other organ in the body. Our kidneys age, right? Our GFR is super high at the beginning of the life, but as we age, our GFR goes down. Something you should remember is that our GFR physiologically never goes less than 60. And then you are going to know why I said this in another lecture. So you see that our GFR comes down. Should I learn this? Should I memorize these numbers? Absolutely not. I don't know these numbers as a nephrologist. I just know the concept. The concept is that our GFR goes down physiologically as we age. Makes sense, right? We don't have the same knees, the same eyes, the same heart. Why would we think that the kidneys will not age when we are older, right? Okay. But the two concepts are that as we age, our GFR goes down. But the main point here is that you see that physiologically, our GFR never goes down less than 60. And you are going to see why I said that later on. Okay. So specific utility of the formula. This is good to remember. There is one of the equations that is called Cockcroft-Gault, and you are going to hear about this later, used for drug dosing. The pharmacists love this because it has weight in it and they go by weight, so their drug dosing is more accurate. CKD epicreatinine, I told you, basically it is something that we use quite often when renal function is close to normal. For people with advanced kidney disease, this goes a little bit off. CKD epi with something that we call cystatin C, and you're going to hear about this again later. It would be best for patients that I take care of. So if you ask me as a nephrologist, what is the most helpful one for you? I will say CKD, epi, cystatin C. For the general population, the name goes with it, epi, epidemiology, CKD, epi, creatinine will do the job. And for the drug dosing, Cockcroft Gold is used more often. So, race has its own lecture tomorrow. So, I'm not going to talk about it too much, but to remind you that up until 4 or 5 years ago, we were really hot on that, saying that when you have certain race, your GFR changes. Now we have removed it because we don't think it is true. I just put this for to remember. Let's stop playing the race card, and then it tells you that, hey, try to get rid of it, and they got rid of it in 2020. Cystatin C is ready for clinical use. I just wanted to, for a warm up, like a workout. It's a warm up for you. We're going to talk about it later. Okay. We talked about serum creatinine, but there is another one that you have used quite a bit. That's called BUN. Some people call it BUN. You can, I don't. BUN is blood urea nitrogen. The normal is 10 to 20. Serum creatinine, if you want to memorize them, should be around 1. BUN, less than 20 is better, right? That's, you want to remember it this way. The positive things about it is it's produced by the liver through the breakdown of the proteins. It is freely filtered, just like creatinine, and it is inexpensive. So these are the good things about urea. Urea is also a good, remember compound X we were looking for? We came up with creatinine. This would be another candidate. The problem with urea is that, first of all, its production is not as constant. Somebody who takes a lot of protein, the BUN might go up. Somebody who is in the ICU has breakdown of the proteins, the BUN is super high. It doesn't necessarily affect their kidney function. It's the production of urea. So it's not as good as creatinine. We use it alongside the creatinine, right? And another problem with it is that it is reabsorbed in the renal tubules. You remember 10, 20% creatinine was secreted into the tubules? Urea is the other way around. It is reabsorbed after filtration. So think about it and don't answer right away. Just think about it. The urine urea has more urea than what was filtered or less urea. Less, right? It was filtered, but some parts were absorbed down the way. So if I just take a urine urea, I might be underestimating my filtration or overestimating. Underest, you know, that's why the nephrologists, we pick 24-hour urine for urea and creatinine, then we make the average. One of them 10 to 20% underestimate, one is overestimate, right? Does that make sense? Yeah, that's what we do. And you are going to have actually a case about it later. It is typically interpreted in conjunction with serum creatinine. So again, the same concept applies. Okay, you see, we have gone far from the first slide that we started. We started by saying that the removal of organic waste products, uremic toxins, for now, you know very well two of our uremic toxins that are one, creatinine, second, urea or BUN. Okay, perfect. But this is not it. I had mentioned without losing blood proteins. That's important. It's not just enough for me that you filter well. You should filter parts, but keep the other sides. You should not filter everything, right? The blood proteins. What do I mean? You come here. This is the afferent goes in. The primitive urine is made, and the efferent takes the blood out, right? Remember here, the blood is coming. This is the three-layer filter that we said. Here, albumin stays here. RBC stays here. Doesn't go to the other side. Doesn't go to the urine. If my albumin, the main protein in the blood, goes in the other side, my kidney is damaged. So, do you think finding a lot of protein in the urine is good or bad? Just your guess. Yes, it is bad. I agree. I agree. It is bad. I just said it should not be passing through the filter. It should be staying on the blood side. So indicator of glomerular disease is proteinuria. That's why when you say protein of 3 grams, I will start to have palpitations, right? It means that the filter is really damaged. Measurement is either 24-hour urine, you do, again, it is cumbersome, but it's very precise, or you do random urine albumin to random creatinine ratio. The normal is, this needs to be memorized, 30 milligram per 24 hours. This is the maximum. What it means is that, you see today I am moving around. If I check my urine albumin in the afternoon, it is probably close to 30. I am moving around, I'm jogging, I'm orthostatic, right? But if it was a Sunday, I was sitting on my couch, eating chips, watching ESPN. My urine albumin would be close to zero. Does that make sense? Does it? Very good. It should never go beyond 30. Up to 30, normal. But more than 30 would be abnormal. 30 milligrams per 24 hours or 30 milligrams per gram of creatinine, meaning that if you do 24 hours, it should be less than 30 milligrams. If you go spot urine, just random urine, it should be random urine albumin to random urine creatinine. The ratio should be less than 30 milligrams of albumin per 1 gram of creatinine. So albuminuria can be the first sign of glomerular disease and may contribute to progression of renal disease. Okay, let's check if Mr. Turner has proteinuria. Turns out that his random urine albumin is 2, random urine creatinine is 92. And let's see, for the units, I had to go to gram. So deciliter, with that deciliter will be canceled. I will be left with milligram per gram. Keep that in mind. The units are super important in nephrology. So 2 is not divided by 92. 2 is divided by 0.092. We do it and it comes out 21. Since it is less than 30, he's in a good shape. He had good filtration. His GFR was, I don't know, 95, 100, really good. And he's not losing protein, right? Proteinuria, the first sign of glomerular disease. He does not have protein. Let's go back to filtration elimination. It was not just the blood proteins. Something else should not be lost in the urine. What's that? Blood cells. Filtration should be good, but proteins and cells should not be going either. Again, the same concept of glomerulus. And here we have, this is the 3-layer of our filter. These are the RBCs. They should not go to the side of the urine. If they go, we have hematuria, another sign of glomerular disease. Are we good? Two things, proteinuria, hematuria, signs of glomerular disease. We can have gross hematuria. You look at the urine, it's all red, or at least it is pinkish, depending on how much blood is out. Or you can have microscopic. You put it under the microscope, and this is normal RBC. You see the concave thing, there is a halo inside them. These are really healthy looking RBCs, perfect RBCs, round at the same time with the halo inside. Come to this side. Do you see this? This is the sign of an RBC who was inside the glomerulus, was trying to go back, but the glomerulus was not healthy. So it pushed it through the filter, passed through the filter, had to change its shape. The shape has been changed to be able to pass through the filter. This is a sign of glomerular disease. This is the hematuria we are really worried about, because sometimes we have bladder cancer and there is blood in the urine, but that's not coming from the glomerulus. That's healthy looking RBC. The RBC that is dysmorphic is the bad. And we call dysmorphic RBC acanthocytes. In some of the tests, they just want you to know the name. When somebody tells you acanthocytes, that person is telling you glomerular disease. Buzzword. Acanthocyte, dysmorphic RBC, glomerular disease. And I am so proud of our microscope at the University of Florida. I put this for myself. Look at these beautiful RBCs here. Look at that here. We call them, actually, if you think about it, we call them Mickey Mouse in Florida. Look, This is a Mickey Mouse. Two sides coming out. Another one. Look at this is more Mickey Mouse here. Glomerular disease. Not that we call it. It's really Mickey Mouse they call it. But oh yeah, I forgot to tell you this. And when the RBCs are a lot, they make a cast. This is another sign of glomerular disease, RBC cast. When you see this or you see this, you don't have a lot of things to do. You know that you're dealing with a glomerular disease. Another thing is the urine dipstick. You might have seen it in your doctor's office. They put your urine in one of these ones and then they put this inside. It's kind of a qualitative. Then they compare it with their standard. So this is qualitative because you might see that, oh, I think it is this. And I might say, no, I see it like this or I see it like this. So it is qualitative. It gives you an idea. It's good for screening. If you put it in, everything is not normal, then you have to go and do the real urine analysis. So dipstick is a good screening tool. So if it is all normal, forget about it, you're good. If it's something is abnormal, you don't try to figure out with dipstick. You go to the next step, you do urine analysis. These are the things that it looks from the glucose, bilirubin, all the way to leukocytes and everything. It gives you a good idea of what the urine looks like. Urine osmosis. Oh, this part, I don't know if you have it in your handout. You can remove this. You don't need to know about the difference between urine osmolality and urine specific gravity. This was just at some point that I thought I need to talk about it, but USMLE doesn't want it from me, so forget about it. These are different casts and crystals. This is, again, RBC cast. It's not as beautiful as mine, but it is also a sign of RBC thing. That's WBCs. They are bigger and they have 2, 3 nuclei. So it's easy to recognize. The crystals are really classic oxalate, and you see the RBCs down there, right? I think those RBCs seem to be normal. I don't see a Mickey Mouse. Okay. Do you want to do a USMLE question, which is really fun? It's really fun, this one. I don't know if I gave you the answer, by the way. Hey, anyways, one day after a 10-kilometer race, a previously healthy 42-year-old man comes with dark urine. Okay. Urine analysis is this. Dipstick shows this. Then, because it is abnormal, I go to microscopic examination. Which of the following is the most likely cause of this finding? Acute glomerulonephritis or glomerulopathy, renal infarct, rhabdomyolysis, hypovolemia, renal vein thrombosis. Something should be bothering you in this test. That's what I'm looking for. Please be bothered by something. Think about it, look at it. Something should be just not feeling well. Is there something you can come up with? One tells you there is blood. This one tells you there is no RBC, right? That should be the trick. That's the key. The dipstick tells you there is blood in this urine. Then you look under your microscope, no blood whatsoever, no RBC whatsoever. That's a classic presentation of rhabdomyolysis because dipstick cannot make a distinction between hemoglobin and myoglobin, that is from the muscles. When I am on the earthquake, my muscles is crushed. There's myoglobin in my bloodstream and in my urine, right? So basically, the dipstick is reading myoglobin as hemoglobin. So it is a rhabdomyolysis, basically breakdown of my muscles. Does that make sense? That's why you don't see any RBC. There's no blood in the urine. It has been myoglobin. Rhabdomyolysis, when you see a discrepancy between dipstick and microscopic examination in terms of RBCs. USMLE buzzword. Dipstick positive for blood, urine microscopy negative for RBC, classic rhabdomyolysis, myoglobin in the urine. Okay. Another thing we do is imaging. We do, I would say, ultrasound of the kidney. We look at the cortex. We look at different parts of at size of the kidney. Small kidneys mean shrunken kidney, chronic kidney disease. Cortex, when it is thin, it is chronic kidney disease. Echogenicity is important. We compare it to the liver. It should be less echogenic, has less echogenicity than the liver. If it is increased, It is fibrosis, again, chronic kidney disease. Okay, this is how we go from the back, and this is that's for the biopsy that we do, kidney biopsy, another way of looking at the kidney function, and that's pretty much it. Thank you very much. Let's see what time it is, and 8:53, 9:03, we start our next session. Thank you very much.